Hello all, this is Dr. Alsip. So we've talked about the bones, we've talked about the joints, and now let's talk about the muscles of the head. And for the most part, we're going to kind of compartmentalize them into their functional groups. We'll talk about basic location, basic innervation, basic actions. So quite a bit to go through, so let's get started. And we're going to start with the muscles of facial expression, and they are exactly what they sound like. They are muscles that will allow us to kind of move the skin to be able to smile or frown or, raise our eyebrows and shock, those types of things. These are going to be considered muscles of facial expression. And they're unique in the fact that they will have a bony attachment site, but their more distal attachment is going to be associated with the subcutaneous tissue, as well as the fascia of the scalp, face, and neck, and that allows for movement of skin rather than movement of joints and bones. These are going to be innervated by the very aptly named facial nerve, which is cranial nerve 7. And so this is going to be kind of our first foray into understanding better what is going to be the motor innervation for these muscles. If there is damage to the facial nerve, that can affect the actions of those muscles. And so facial paralysis, often referred to as Bell's palsy, is one of the best examples of this. So in this particular disorder, the facial nerve is somehow compromised. It could be pinched, it could be severed in very severe cases. But what will happen here, so say the facial nerve has been pinched in this general region, this will cause for all those branches that are going to the muscles to not be working correctly. And that will lead to unilateral paralysis, so inability to move of those facial muscles. And so remember, we have a facial nerve on each side. So if my right-sided facial nerve has been compromised, the muscles on the right side of the face would be compromised, but the left side should still be functioning. And what this will present as is kind of basically, these muscles don't work. So there'd be a drooping eyelid. You wouldn't be able to wrinkle the brow or raise the brow. Importantly, there'd be a drooping of the corner of the mouth, and things would kind of get stuck. Food, say, would get stuck in the oral vestibule in this region. Sometimes individuals with Bell's palsy have to kind of pull out food from the oral vestibule region. There are many, many, many muscles of facial expression, but we're really only going to focus in on 3 as they're easy to identify. 2 of these are going to be considered sphincteric muscles. So a muscle that is a sphincter generally is going to be surrounding an opening. Usually their muscle fibers are going to be circular in terms of directionality. And so the first one we're going to discuss is the orbicularis, so basically orbiting oculi, okay? So this is going to be a muscle that is surrounding the orbital region. And it's going to function in terms of closing the eyelids, all right? Allowing me to be able to wink at you right now. So that is going to be the orbicularis oculi. It's a rather large muscle, kind of hard to miss. The second muscle I want you to be aware of is the buccinator muscle. Sometimes you'll hear it buccinator, but generally buccinator is what you're going to hear. And anytime you hear or see this term bucce anywhere within, you're going to be thinking in the general cheek region. And really, this is forming most of the muscular portion of the cheek. Actually, a good amount of the cheek is actually going to be formed by subcutaneous tissue or a fatty layer. But deep to that is going to be the buccinator. And I have this here, and I want you to note that most of these muscles are very, very, very close to the skin. But the buccinator is a little bit on a deeper plane, but still considered a muscle of facial expression. So during life, this would be filled in with fat right here. And the buccinator is deep to that. A lot of times you see the buccinator's main action is being able to do this, kind of blowing out the cheeks. And that's true. It can resist distension, but really its major role is being able to press the cheek against the molar teeth. And that allows for, say, a food bolus to be able to go in the correct direction, towards the back of the oral cavity. So it's keeping food out of that oral vestibule and getting stuck in this region. So if this is paralyzed, then food would get stuck because that buccinator isn't working correctly. The last muscle I want you to know in terms of muscles of facial expression is another sphincteric muscle, which is the orbicularis oris. All right, so this is going to be surrounding the lip region. This will close the oral fissure, as well as allow for protruding of the lips. So these are our kind of two first introductions to sphincteric muscles. So all these are innervated by the facial nerve, in addition to all these other muscles that we're not going to get into a lot of the detail there. Okay, moving on. There are going to be muscles that move the eyeball. These are often referred to as extrinsic eye muscles. Sometimes you hear them also referred to as extraocular eye muscles. And these are going to have some form of a bony attachment. This is why it's extrinsic, because it's going to originate outside of the eyeball. But its distal attachment, all of these muscles, distal attachment is going to be on the sclera of the eyeball. And this is the sclera colloquially is referred to as the whites of the eye. And so all these muscles are going to attach on the sclera, and when they contract, they're going to move the eyeball. Most of these muscles are innervated by the ocular motor nerve. Kind of tells you right there in its name. It's the motor nerve in terms of the ocular muscles, and this is cranial nerve 3. So I mentioned most of them, not all of them are. We're not going to get into the details of the other two, but for the most part, we're going to be satisfied with most of these are innervated by oculomotor. Now, there are some more complex movements associated with the extraocular eye muscles with intorsion and extorsion, but we're really going to focus on the ones that are easier to visualize. And so these muscles, depending on which one, are capable of elevating the eye. So if you think of kind of looking up or depressing, looking down, you know, this is why your ophthalmologist will kind of have something and move around their pen. So looking down is depression. Abduction is looking towards the side. Adduction, think looking towards the nose. So those are kind of the main actions that are really easy to visualize that these muscles can do. All right, muscles of mastication. So these are going to be the thickest muscles of the head. These are going to move the mandible, so they're going to be functioning at the temporomandibular joint. And these are innervated by the third division of the trigeminal nerve, which is often referred to as the mandibular nerve, which is well named because this is going to move the mandible. Not all of V3 or the mandibular nerve is going to be motor. It certainly has a very important sensory component as well, but for what we're talking about, V3 is going to innervate these muscles of mastication. Kind of the main action that the muscles of mastication do, or let's say the more powerful action, is going to be elevation of the mandible or closing the jaw, all right? Closing the mouth. That's the more powerful one. One of these muscles is going to be capable of depression. And then you remember protraction, jutting out the jaw, and retraction, bringing it back. Those are going to be other actions that are possible here. I do want you to be aware of the location, general location of these 4 muscles. There are 4 muscles of mastication. The first 2 we're going to discuss are palpable, meaning that you can feel them. When I'm contracting my jaw, I can feel up here around my temples the temporalis muscle. So this is going to have an attachment on up on the parietal bone at the superior and inferior temporal lines. And then it's going to have its distal attachment on that coronoid process of the mandible that we talked about, that more anterior projection of the ramus. And so it makes sense. All of these muscles are going to have their distal attachment on the mandible because that's the movable bone. So the temporalis is the more superior one. It's a bit more fan-shaped. Whereas the masseter muscle, sometimes you hear it referred to as the masseter muscle, is also palpable. So if you contract right here, you can feel your masseter right here on the side of your mandible. This is another very powerful muscle. It's a rather thick muscle. It's going to be on the superficial side of that ramus of the mandible, so that vertical part of the mandible. And it's going to have a friend on the opposite side, or the deep side of the mandible, that's referred to as the medial pterygoid muscle. So very similarly shaped muscle, but it's going to be on the deep side of the ramus, so it is not palpable. So temporalis and masseter muscles are palpable. The medial pterygoid muscle is not, as well as the lateral pterygoid. These are much deeper muscles. The lateral pterygoid muscle I want to spend one moment on here is a little unique. It has two different heads. You have a superior head and an inferior head. The superior head actually has a direct attachment to the articular capsule and a bit on the articular disc of the TMJ joint. So it really plays an important role in terms of stabilization of the TMJ. And I do have a note here is it is the only muscle, the inferior head is the only muscle that will depress the mandible or forcefully open the mandible. Had a little pop in my TMJ right there. All right, so this is the only muscle that's going to be capable of that. There are a lot of other muscles that we're just going to discuss as groups, and the first of these are going to be the muscles of the soft palate. There are 5 muscles of the soft palate. Really, 2 of those 5 are the ones that play the bigger role. These are going to play a role in terms of elevating to the, so here we have the hard palate. And then the soft palate is this muscular portion kind of back here. And you have the palatoglossus. This is going to be one, the palatopharyngeus, which is, you see the arch is kind of that mucus covering that portion of the muscle. So those are 2 of those right there. You don't see some of the other ones, the tensor veli palatini or the levator veli palatini, but they are going to be in this general region here, covered up with this this type of mucous membrane right in this region. You have this general location right here. You can elevate and you can depress the soft palate. You can make the palate taut. It can kind of close off and separate regions. So this is an important region behind the hard palate. These are going to be innervated by the vagus nerve, except for one of these, and you don't need to worry about which one. But for the most part, this group of muscles is going to be innervated by cranial nerve 10. So one of the first kind of groupings that we'll talk about, and vagus is going to keep coming back because it's hugely important in terms of parasympathetic innervation. But it does play a role in terms of somatic motor for certain groups. And this is the first one we'll talk about. Lastly, I do want to talk about the muscles of the tongue. The tongue is a fairly large structure. It is a very muscular structure covered by mucosa, of course, as anything in the oral cavity region would be. Really, we can divide these into 4 major regions. They're the extrinsic muscles of the tongue, which will originate outside of the tongue and then distally attach to it and form part of the tongue. These are going to play, this will alter the position of the tongue, so allowing us to kind of stick out the tongue or move it to the side, those types of bigger movements. Whereas the intrinsic muscles of the tongue, of which there are also 4, these attach entirely, they originate and insert entirely within the tongue. These will be the kind of finer scale alterations of the shape of the tongue. So, you know, kind of being able to move around the tongue in much kind of smaller movements or more precise movements. These all are going to be innervated by the hypoglossal nerve, which is cranial nerve 12, except for one. Again, don't need to worry about that exception to the rule here, but this is going to be cranial nerve 12. All right, excellent. So there's a lot going on in terms of muscles of the head. Some of these, you're going to have some attachments from the neck into the head, and we'll talk about some of those as we discuss those muscles. But let's do a quick review here. An individual has a damaged vagus nerve, which is cranial nerve 10. While this has tremendous implications in terms of the gastrointestinal system, also the larynx and the pharynx, and some of the parasympathetics associated with the heart, etc. And you'll talk about that in more detail in other sessions. It can also affect the actions of certain muscles associated with the head. Which group of muscles would that be? So take a moment, try to answer this question. And when you're ready, let's talk about how D, muscles of the soft palate, is correct. So almost all the muscles of the soft palate are going to be innervated by the vagus, except for one. It's not going to be the extraocular eye muscles. These are mostly going to be cranial nerve 3 or the oculomotor nerve with a few exceptions. So not this one. Muscles of facial expression. Do we remember what that one's innervated by, or this group? Cranial nerve 7. Or the facial nerve, so not that. Muscles of mastication, that's not vagus. That's going to be the 3rd division of the trigeminal nerve, or V3, or mandibular nerve. You'll hear that numerous ways. And then it's not going to be muscles of the tongue. Almost all. There's one that's actually innervated by vagus, but we're just going to pretend like that one. We're going to go with the general rule, which is actually going to be all these are innervated by cranial nerve 12 or the hypoglossal nerve, except for one. So that's kind of the rule, not the exception. All right, excellent. So we have covered all the bones, joints, or not all of them, but some of the big picture bones, joints, and muscles of the head. Now we're going to move into the neck and the back. I'll see you in the next session. Thanks.